Hi, I'll be speaking about stridor in children. What are the abnormal sounds that one should evaluate in children? Snoring, stridor, wheezing, cough, and grunting. Snoring is low pitched inspiratory sound produced during sleep. Stridor is a high pitched monophonic sound that can be heard without a stethoscope. Wheeze is a continuous, usually high pitched whistling sound that is accompanied by prolongation of the expiratory phase. Cough can occur whenever and wherever the cough receptors are stimulated. Grunting is a short, hoarse, moaning like sound which is occurred when a partially closed glottis halts the expiratory flow of air. The airway sounds are which arise from nose and nasopharynx are snuffles and snorting. From oropharynx or hypopharynx is snoring. Larynx and trachea, the sound produced is stridor, and the sound produced from the airways and lungs wheezing and grunting. So the first sound is snoring. The second sound is stridor. And the third sound is grunting. So, what will you observe clinically when you hear the abnormal sounds? Obviously, it will be increased work of breathing in the form of nasal flaring, suprasternal retractions, sternal retractions, subcostal retractions, and intercostal retractions. Now, let us see where is the lesion and how is the sound produced, where and what kind of a sound produced. So, if the lesion or obstruction is at nasopharynx and oropharynx, the sound produced would be snoring and stutter. There will be nasal flaring, but usually no retractions. If the obstruction is at larynx or glottis, there will be suprasternal retractions, there will be stridor and no cough. If the obstruction is at extrathoracic trachea, there will be sternal retractions and there may will be stridor and cough. If the obstruction is at intrathoracic trachea, there will be sternal retractions, there will be stridor, wheeze, and cough. All three can occur together. If the obstruction is in bronchi, there will be subcostal retraction and there will be wheeze and cough. If the obstruction is in alveoli or the interstitium, there will be intercostal retraction and there will be grunting. So upper airway lesion, what are the upper airway lesion which cause noisy breathing? So there can be choanal atresia, unilateral, there can be adenoidal hypertrophy, there can be tonsillar hypertrophy, there can be macroglossia, there can be epiglottitis because which is the inflammation of the epiglottis. There can be all the lesions below the glottic and subglottic region can cause stridor. Then any obstruction with the extrathoracic trachea will lead to stridor. This is the supraglottic region and this is the infraglottic region. Now, what are the important points in history when you hear the abnormal sounds? So, just remember the mnemonic specs, severity, whether it is mild, moderate, or severe, progression as to how there has been the evolution over time of the sound, how and what is the relation to the body position, how is the sound related to eating, feeding, is there an aspiration and failure to thrive, is there cyanosis associated with the sound, and if the sleep is disturbed or retractions are increased during sleep, and what is the age of presentation. At birth, all the lesions that are present at birth would present like congenital vallicular cyst, laryngeal web anatresia, congenital subglottic stenosis, bilateral vocal cord palsy, because they are going to obstruct the airway completely, so they will present at birth. Now at the age of 2 weeks to 4 weeks, it could be laryngomalacia or laryngoesophageal cleft. At 1 to 4 months, laryngomalacia, moderate subglottic stenosis or subglottic hemangioma. Above 1 year, most of the time it would be infective causes because the congenital causes may have presented much before 1 year, barring a few congenital causes which may present a little later, which are, if say about Webb is mild, then it may present much later. So the lesions that present above 1 year are croup, hypertrophied adenoids, foreign body of the aerodigestive tract, laryngeal papillomatosis, retropharyngeal abscess, and bacterial tracheitis. What are the aggravating factors? So, if the sound worsens on crying or straining, you are sure that you are dealing with the laryngeal anomalies like laryngomalacia, bilateral vocal cord palsy, or subglottic stenosis. If the sound worsens during sleep, then the obstruction is at nasal or the oropharyngeal level. Then it can be adenoidal hypertrophy or tonsillar hypertrophy, or the child may be having retrognathia. If the sound worsens during feeding or deglutition, then there can be a unilateral vocal cord palsy or tracheoesophageal fistula or laryngeal cleft. Now, how the sound changes with position? So, if the noise is decreased on proning, could be laryngomalacia, vallicular cyst, micrognathia, macroglossia, or vascular rings and slings. So, all these things in history will give a clue as to what the lesion can be and where the lesion can be. Now, what is stridor? Stridor is an abnormal, high pitched, monophonic respiratory sound produced by turbulent airflow through a narrowed airway structures. Derived from the Latin word stridere, meaning to make a harsh noise or a shrill sound so as to creak. Its presence suggests obstruction of the airway at the level of larynx or extrathoracic trachea. Now, what causes stridor? We remember the Bernoulli's principle. As the speed of a moving fluid increases, the pressure within the fluid decreases. When the airflow is forced through the narrow tube, a local area of low pressure creates a vacuum effect distal to the narrowing. The focal area of low pressure distal to the narrowed airway causes the airway walls to collapse and vibrate, generally leading to a high pitched squeaking sound that is characteristic of stridor. Now, if there is an obstruction in the extrathoracic trachea, when the child is during expiration, we know the intratracheal pressure is more than the atmospheric pressure, so air can pass out smoothly, and even despite the expiration we will not hear a sound. But during inspiration, we know that the tracheal pressure is less than the atmospheric pressure, so when the air passes from outside to inside, the narrowed air further gets narrowed and a stridor is produced. Now, the types of stridor are inspiratory stridor, heard generally during inspiration, and they originate from obstruction in the extrathoracic region and mainly at the larynx. The expiratory stridor generally originates from obstruction in the intrathoracic region. Biphasic stridor, as the name explained, it is present during inspiration and expiration. It typically indicates a fixed rather than a dynamic central airway obstruction. The stridor may be more evident in either phase of breathing, expiration or inspiration. Now, why is stridor important in children? Here in this cartoon, we can see that the above is the airway of an infant and the lower cartoon is that of an adult. We see that the airway diameter is around 4 mm in a newborn infant, and during it, if there is edema, we see that the diameter reduces to 1 mm. So there is a reduction of 75% of the lumen if there is swelling inside in the lumen of infant. Whereas in adults, we know the diameter of is much more, that is 8 mm. But if there is swelling, it reduces to around 3 mm. So we see that there is just an obstruction of less than around 44%. in adult. So there is still quite a bit of room to for the air to pass, and we know that resistance is inversely proportional to the fourth power of radius. So that is the reason even a marginal reduction in caliber of small pediatric airway can precipitate dangerous obstruction to airflow. That is why it is very important for us to know about the what is the cause for stridor and treat the stridor accordingly. So there are certain inherent differences in the airways of infant and adult, and we ought to know that the nostrils are are small, and the newborns are obligate nose breather. So even a slight blockage of the nose may lead to respiratory obstruction, respiratory distress and obstruction. The occiput is round, so even slight flexion of neck uh, may lead to respiratory distress and obstruction. Tongue in infant occupy the major portion of mouth, whereas in adult it does not. There is quite a lot of room left inside the mouth. The epiglottis we know is omega shaped and floppy in children, whereas in adult it is straight because of the cartilage present. Larynx is higher in infant, whereas it is lower in cases of adults. The vocal cords are slanting anteriorly in infants, whereas they are horizontal in cases of adults. The neck is short. The cricoid ring is the narrowest diameter, which is present at the C4 level, whereas the narrowest diameter in adult is at the level of glottis. The other differences are lungs are still growing in infants, airway are smaller throughout, all the airways are smaller, the ribs are horizontally placed, so the respiratory muscles get fatigued easily, so any child would go land up into respiratory failure sooner than any adult can. So this is the normal anatomy of the upper airway, which one can see from outside. This is funnel shaped larynx. We can see it is the white portion, funnel shaped, is the supraglottic area. Then there is a glottic area, and then there is the cricoid cartilage. So cricoid cartilage is the narrowest portion of the infant's upper airway, trachea. Now, when we go, this is the laryngoscopic view of the glottic area of the larynx. So, we ought to know all the structures. This is vallicula, this is epiglottis, this is tubercle epiglottis, this is piriform recess, this is cuneiform cartilage, and the cornuvate cartilage. And this is trachea, these are ventricular fold, this is vocal fold, and this is aryepiglottic fold. We know that the larynx is surrounded by 3 paired and 3 unpaired cartilages. The unpaired cartilages in adult is epiglottis, thyroid, and the cricoid cartilage, whereas in children the epiglottic cartilage is not so firm, and that's the reason why it is so floppy. And the paired ones are the cuneiform cartilage, the corniculate cartilage, and the aryepiglottic cartilage. So what forms the upper way? What are the structures in the supraglottic region? Are nose, nasopharynx, oropharynx, and hypopharynx, epiglottis, larynx, aryepiglottic fold, and false vocal cord, whereas the glottic and subglottic region are constituted by the vocal cords, the subglottic space, the extrathoracic segment of trachea. The supraglottic region has no cartilaginous support, so it is very prone to collapse, whereas the glottic and the subglottic region is surrounded by the cartilages, which I just enumerated, so it is less vulnerable to collapse. And the subglottic space, as I told you, is surrounded by cricoid cartilage, which is the narrowest part of trachea. The diameter of subglottis gradually increases from 4 mm at birth to 1.5 centimeter during the adulthood. Now, what are the causes of stridor? We can divide as acute, chronic, and iatrogenic. All the infective causes like croup, epiglottitis, retropharyngeal abscess, bacterial tracheitis, peritonsillar abscess, are the causes for acute stridor. Then foreign body aspiration, anaphylaxis, and airway injury are also acute causes for stridor. In chronic, we can consider all the congenital causes and the acquired ones like vocal cord palsy, subglottic stenosis, tumors, and papillomatosis. Then iatrogenic causes may be post-intubation due to airway burns and airway trauma. The other way to classify the causes for stridor is to congenital and non-congenital. The congenital causes of stridor are the lesions at larynx and subglottis are laryngomalacia, laryngeal cyst, vallicular cyst, laryngeal webs, laryngoesophageal cleft, vocal cord paralysis, subglottic stenosis, supraglottic stenosis, and subglottic hemangiomas. The lesion at trachea are tracheal stenosis, tracheomalacia, vascular rings or slings, and the bronchial lesions are bronchogenic cysts. So, the non congenital causes of stridor are infections, ALTB, croup, epiglottitis, tracheitis, retropharyngeal abscess, diphtheria, laryngeal papilloma, and others are laryngeal trauma, anaphylaxis, foreign body, caustic burns, and vocal cord dysfunction. So, in my this talk, I will be just dealing with congenital anomalies. So, laryngomalacia constitutes 60% vocal cord paralysis, 15 to 20%, subglottic stenosis 10 to 15%, webs and atresia 5%, subglottic hemangioma 1.5 to 3%, saccular cysts and laryngoseals 2%, cleft larynx and trachea 0.5 to 1.5%. So we will be taking cases of all kinds of congenital anomalies. So this was a 2-month male, well thriving, noisy breathing for 10 days. Inspiratory stridor increased on crying and decreased on sleeping. So this was the stridor, and we did the bronchoscopy, and we found that there was a omega shaped floppy epiglottis covering the entire glottic opening. So we know that this is laryngomalacia. And another child, 3-month-old, with failure to thrive and severe stridor, we went ahead and did the bronchoscopy, and we saw that the epiglottic fold on the right side was going inside the glottic opening and blocking the glottic area. So that is the reason why he was failing to thrive. So this is laryngomalacia, which is the commonest anomaly, laryngeal anomaly leading to stridor in infant. It may be associated with other airway lesions. This is due to collapse of supraglottic structures during inspiration. Noisy breathing starts a few weeks after the birth. This abnormal sound increases while crying, feeding, agitation, supine, or during URTIs. These are the various types of laryngomalacia: type 1, type 2, and type 3, when the epiglottis folds completely inside the glottic opening. The few children present with feeding difficulties, coughing, and poor weight gain. The vast majority are self-limiting, and they tend to resolve by 24 months as the airway grows. The likely cause is delayed neuromuscular development, and the diagnosis is by flexible fiber optic laryngoscopy. All that is needed is regular follow-up and a close watch on weight gain, and feeding with up in an upright position and sometimes thickened feet may also help. Surgery is indicated only in very few cases, less than 10% of cases, and like when there is failure to thrive, there are recurrent aspirations, and there is recurrent respiratory distress and cyanosis. The procedure done is supraglottoplasty, eriepiglotoplasty, and or tracheostomy. Another child, 2.5-month-old infant, history of respiratory distress, stridor, apnea, poor feeding. He came to us with seizures, which was post-apneic. We did the bronchoscopy, and we found that there was a structure completely obstructing the glottic opening. It was pressing over the epiglottis. So we know it is a vallicular cyst. We did the MRI and found that it was a vallicular cyst. So vallicular cyst contains respiratory epithelium and mucous glands. They arise in hypopharynx between the glottis and the base of tongue. They present with feeding difficulty, failure to thrive, stridor, apnea, noisy breathing, or respiratory distress. Diagnosis is confirmed with flexible fiber optic laryngoscopy, and the treatment is marsupialization of the cyst. Another infant, a 1 year old infant, history of respiratory distress since birth. There was failure to thrive, severe stridor, and poor feeding. This child was being treated as laryngomalacia, but since there was a failure to thrive, this needed a bronchoscopy. And what we saw in bronchoscopy was a cystic structure completely blocking the glottic opening, and it was a vestibular cyst. We went ahead and removed the cyst in toto. So, what are the vestibular cysts? They are abnormal dilatation of the laryngeal saccule and arise in the region of laryngeal ventricle. They are the outpouchings of the saccular mucosa. They are fluid filled submucosal cysts that are covered by normal mucous membrane and isolated from the interior of larynx. Diagnosis is done by flexible laryngoscopy, and treatment is cyst removal in toto. A 4-day female delivered by forceps at the PHC. There was a delayed cry. This child presented with stridor and distress. We went ahead and did the bronchoscopy, and we found that the left vocal cord was not moving at all. So it was a left vocal cord palsy. So vocal cord palsy can be bilateral, unilateral. They can be idiopathic, iatrogenic, or congenital. In bilateral palsy, there is almost always severe airway obstruction and stridor. In unilateral palsy, the stridor may be absent and the lesion may manifest by a husky or a weak cry, but in infant it is usually stridor. It may be secondary to neurogenic disorder like Chiari-2 malformation, hydrocephalus, meningocele, hypoxic cerebral palsy, and cerebral hemorrhage. In iatrogenic can be due to cardiothoracic, post-cardiothoracic surgery, invasive mechanical ventilation, thyroidectomy, or tracheoesophageal fistula repair, or after forceps delivery. There is a high rate of spontaneous return of function whenever there is a unilateral vocal cord palsy. Almost in 70% it recovers on its own. We have to wait for 1 year for corrective measures like airway widening, because there is a spontaneous resolution. But in cases of bilateral vocal cord palsy, one may need to do an urgent tracheostomy and manage it at a later date. A 4-year-old child came with husky voice since birth and mild stridor on crying, but the parents were suggested to wait and watch. But this child came to us and we did the bronchoscopy and we found a partial web. So this was a laryngeal web. Laryngeal webs are usually located at the level of glottis, supraglottis, and the subglottic area. The webs may be complete or incomplete and they vary in thickness. The laryngeal webs are of many varieties. They can be starting from type 1, which is involving the 35% of the glottic length, type 2 35 to 50%, type 3 50 to 90%, and type 4 when there is a complete glottic length is involved. So these are the kinds of laryngeal web. They are caused by failure of resorption of the epithelial layer of the laryngeal opening, resulting in incomplete separation of the vocal cords. Complete webs cause respiratory distress at birth, and partial webs produce stridor, weak cry, and respiratory distress. Approximately 10% have other associated anomalies. Treatment is surgical and depends on degree of airway obstruction. A 6-month-old child came with stridor and cough. There was history of recurrent cough since birth, which needed antibiotics, and the cough increased with feeding. So there is a clue that the cough is increasing with feeding. So that means we are dealing with some kind of an aspiration syndrome. We went ahead and did the bronchoscopy and found type 1 cleft, laryngeal cleft. So laryngeal cleft can also be divided into 4 kinds. The first one is only interarytenoid. The second is partial cricoid is involved. In the third type, the entire cricoid is involved, and in the fourth type, the cleft is present up to the carina. So this is type 1, type 2, and type 3. So this is because of the failed fusion of 2 lateral growth centers of the posterior cricoid cartilage at 6 to 7 weeks of intrauterine life. 0.3 to 0.5% of congenital anomalies of larynx constituted by the laryngeal cleft. The male-female ratio is 5:3. There are increased secretions, feeding difficulties, failure to thrive, wheezing, stridor, noisy breathing, aspiration, respiratory distress, recurrent pulmonary infection, and or hoarseness. And treatment is surgical. Another 2-month-old child came with severe stridor and poor weight gain. He had been on ventilator for 7 days in the neonatal period. So we see that this is the severe stridor and severe intercostal and subcostal retractions, and we went ahead and did the bronchoscopy, and we found subglottic stenosis, and we did the balloon dilatation. This is immediate post dilatation, and the child needed subsequent 2 to 3 balloon dilatation, and the child is fine now after 1 year. Another child, 1 month old, came with stridor since birth, severe stridor after URI, and there was poor weight gain. So this was a congenital subglottic stenosis. So subglottic stenosis, there is a Mayer-Cotton classification of grades. So grade 1, when there is a 50% of obstruction, grade 2, 50 to 70% of obstruction, grade 3, 71 to 99% of obstruction, grade 4 if there is complete obstruction. So ours was grade 3 in first case. In both the cases it was grade 3 obstruction and it needed treatment. Narrowing of the lumen of cricoid cartilage leads to subglottic stenosis, and this is possibly caused by incomplete canalization of the cricoid ring, which diameter is less than 4 millimeter in term infants and 3 millimeter in preterm infants. It can be iatrogenic like post intubation, and the treatment will depend upon the type of the stenosis. So in the first case we needed just a balloon dilatation, and in the second case we needed to do the cricoid split. A year-old child came with biphasic stridor since the age of 6 weeks, failure to thrive, and there was a hemangioma over the left arm. So if the hemangioma is there over any part of the body and the child has stridor, then we thought we would find a hemangioma, and we did find a hemangioma on bronchoscopy. And a closer look, it was completely blocking the lumen. So it is the subglottic hemangioma may lead to stridor. So 4 to 5% of children with subglottic hemangioma will have cutaneous hemangioma. The hemangiomas proliferate over first few weeks of life, followed by involution between 8 to 12 months. Their inspiratory stridor develops over first 4 to 12 weeks of life. There are feeding difficulties and failure to thrive. The diagnosis is by laryngoscopy, and ultrasonography and MRI should be done to make sure that this is hemangioma, and we did that in this case, and it turned out to be hemangioma only. And the treatment is propranolol 1 to 2 milligram per kg. Sometimes you may need to give it for a year along with the short course of prednisolone 1 to 2 milligram per kg. Another child, a 7-month-old male child weighing 6 kg, history of meconium aspiration syndrome. He was ventilated for 7 days, was all right until 7 months. He came with sudden onset of severe stridor. We went ahead and did the bronchoscopy, and we found a cystic structure in the subglottic area, and on a closer look, this cystic area was completely blocking the subglottic region. So this was a subglottic retention cyst which was post intubation. It sometimes can be congenital also, and all you need to do is a marsupialization of the cyst after confirming it with the laryngoscopy. Another child, a 7-month-old child with failure to thrive and severe stridor with respiratory distress since birth. So this child has severe respiratory distress since birth. So we did the bronchoscopy, and we found complete tracheal rings. So there can be narrowing, and this results from complete or nearly complete rings of the tracheal cartilage, and they can be, in 50% of cases, they can be segmental stenosis. It can be generalized or complete stenosis in 30% of cases. If pulmonary arterial slings are associated, maybe in 20% of cases, it can be a funnel shape. The diagnosis is done by bronchoscopy and treatment is surgical. So, in this case, we did the slide tracheoplasty. A 9-month-old boy weighing 8 kgs was referred for sudden severe respiratory distress. So this we can see that there is severe inspiratory stridor. We thought there was a foreign body. We did an X-ray and we found there soft tissue shadows bilateral on both sides of the trachea. We went ahead and did the bronchoscopy and we found there anterior trachea, the upper trachea, there was a pulsatile mass. We thought it was a kind of a vascular ring or something, but we went ahead and did CT angio, and CT angio was normal, but CT showed that there was a cystic mass extending from the neck to the xiphoid cartilage, and we subjected this child to cardiothoracic surgery and it turned out to be a cystic hygroma. Another 13-month-old male child, full term, 7 kg, history of frequent cough, vomiting, noisy breathing, feeding difficulties, and cough was like a bark of a seal. And there were history of recurrent respiratory infections. First episode occurred at the age of 3 months. This child liked to sleep in prone position and the stridor decreased in prone position. So it gives us a clue that there could be all those causes which decrease when the stridor is decreased on proning. And so we went ahead and did the bronchoscopy. We found a extra bronchial pulsatile mass suggesting a vascular ring. We did the CT angio and we found a double aortic arch, and the treatment of this is surgical only. The last case, 25 days female, came with respiratory distress on day 3 of life, noisy breathing for last 15 days. There was history of multiple hospitalization, and when the child came to us, there was marked intercostal, subcostal, suprasternal retractions and marked V's. X-ray showed hyperinflation of both the lungs. Bronchoscopy again showed complete obstruction of left main bronchus. So we did CT and CT angio. We saw a cystic mass compressing the trachea. So it was a duplication cyst, and this turned out to be we landed up with doing a surgery, and this child is fine. So the take-home message for the congenital causes of of stridor are that there are major differences in the airways of infants and adults. One must keep in mind while managing the stridor these differences. Children may go into respiratory failure faster than adults because of these inherent differences. Presence of stridor suggests significant obstruction of airflow in the oropharynx, larynx, or in the extrathoracic trachea. So it is a priority to find out the cause for stridor, because even a mild stridor may go up and lead to complete respiratory obstruction. Thank you very much.